treatment, everything, diagnosing everyone. And so a more general overview we should know that who are at risk, how to diagnose, and whom to treat, something like that. But I will restrict myself in newer perspective because that was my topic. So for any medical disease, we have from our MBBS days learned diagnosis, investigation, and treatment. So from each part, I have taken one new thing. What is new in diagnosis? What is new in investigation? What is new in treatment? Not the entire fatty liver disease. Just to start, this is the first paper of 1998 when the fatty liver disease was first time diagnosed based on histopathology of the patients, 17, 18 patients who underwent liver biopsy because of deranged LFT. And that time it was named as non-alcoholic fatty liver disease. Now the name has changed from non-alcoholic fatty liver disease to means NAFLD to MASLD, Metabolic Dysfunction-Associated Fatty Liver Disease, and now recently it is being changed to MASLD, Metabolic Dysfunction-Associated Steatotic Liver Disease. So this was the original term, and why this original term of non-alcoholic fatty liver disease was given because of two reasons. Because at that time, alcohol was the only known cause for fatty liver disease. There were two diseases were known for liver. One was alcohol and second was hepatitis B. But B was not known to cause fatty liver disease. So that is why it was called non-alcoholic fatty liver disease, because the participants were non-alcoholic. And second, the histological feature were very similar to those found in alcoholic liver disease. That was the reason it was named as non-alcoholic fatty liver disease in 1980. And since then we were continuing same thing till 2020 or 22, when name was changed to MAFLD and then to MASLD. So why the name is changed from NAFLD to MASLD? In summary, there are two types of reason. One is scientific reason and there are social reason. Scientific reason is fatty liver disease is associated with metabolic syndrome. As our knowledge grew, we realized that metabolic syndrome is a much more common phenomena and it is associated with adverse outcome. It is component fatty liver disease is one of the liver manifestation of metabolic syndrome, and that is why it is changed to metabolic dysfunction associated steatotic liver disease. And fatty liver disease can coexist with other liver disease. Means somebody who is having autoimmune liver disease is not prohibited to not have fatty liver disease. Why he or she is protected from being fatty liver disease? Or somebody is having hepatitis B, why he or she cannot have a fatty liver disease? So the two diseases can coexist. That was the scientific reason. And the social reason was to give a positive connotation instead of giving a negative connotation by saying non-alcoholic fatty liver disease. And by alcohol we are saying that it is a trivializing the importance, and also saying the fatty people don't like that they should be called as fatty liver. Right? So these are the social reasons why the name was changed. Not very strong reason. India is still stick to NAFLD because it's easy to communicate when you are talking to a physician who is sitting at the end of the country, at the very far-fetched place. So that is why I will also most of the time use either MASLD or NAFLD, but not the other things. Right? So this is the current diagnostic criteria for steatotic liver disease, means which you say as NAFLD. This is the current diagnostic criteria that patient should not have significant alcohol intake, no other significant liver disease, and one cardiometabolic risk factor, no other risk factor is present, then it is MASLD. If you see on the right part of the panel. Means you have to have no other risk factor, significant alcohol intake should not be there, other risk factors should not be there, and there has to be one metabolic risk factor. And these are the metabolic risk factors. Obesity, BMI more than 23 kilogram per meter square, or if you see waist circumference in 1980, or pre-diabetes or diabetes, hypertriglyceridemia, hypertension, or low cholesterol still. The same is important 5 component of metabolic syndrome. So nothing is new, it's just the cosmetically name has been changed. Content wise, definition wise, it is the same. So we need not to worry that what is MASLD and what is NAFLD. They are exactly the same thing. Now, coming to that is the definition or diagnosis you can say. Then the second part is assessment. In any liver disease, whether it is fatty liver, hepatitis B, hepatitis C, alcohol, Wilson disease, PBC, PSC, name any disease, outcome is primarily determined by the degree of fibrosis. So every liver disease ultimately end up in three components, histopathologically if you see. One is fat deposition, steatosis. Second is inflammation, which manifests in form of serum ALT, AST elevation. And third is fibrosis, because ALT, AST is just showing you inflammation. Inflammation leads to healing process, and healing occurs with fibrosis. So ultimately, in any, regardless of the cause, in liver disease, outcome is primarily determined by the degree of fibrosis. So, like any other disease, for fatty liver disease, we have to assess the degree of fibrosis. How much is the fibrosis inside the liver? And that is the crux of assessment. Liver fibrosis progresses from F0 to decompensated cirrhosis. Fibrosis is graded F1, F2, F3, F4 fibrosis. We need liver biopsy, which is very difficult to do in most of the centers. It is costly and also life-threatening procedure. People don't want to do. And F1, F2, F3, F4 fibrosis, what is important is F2 fibrosis is the one which is most important. We need to know. If something is less than F2, we need not to worry. F2 fibrosis is the one which is going to worsen, progress to cirrhosis and other things. Right? So, as an alternative to liver fibrosis, what we are using is non-invasive test. There are a whole lot of non-invasive tests. I will not talk about everything. This is the overall summary of all the commonly used non-invasive tests for liver fibrosis. Broadly, there are two groups. One is elastography, which is basically, you can say, instrument-based, which is very costly. You can use it in hospital setting, which include VCTE, means vibration controlled transient elastography, shear wave elastography, which can be a two-type P, means point shear wave elastography, or 2D shear wave elastography, or MR elastography. So these are very costly, more useful in hospital settings. And the second are the blood tests, which can be done in clinical setting also, in periphery also. And these tests are like APRI, FIB4, NFS, NASH fibrosis score, means extended liver fibrosis panel, ELF, fibrotest, and fibrometer. ELF, fibrotest, fibrometer, these are the patented tests. So we cannot use it because it will cost huge amount of money. What we can use is APRI, FIB4, and NFS, right? And if you see the difference between these tests, APRI include only AST and platelet, FIB4 includes two additional factors, ALT and age, and if you further go down, NFS include another three factors, that is albumin, BMI, and diabetic mellitus status. So, as you increase the number of components, your predictability increases most of the time, provided your sample size is good. And that is what is happening here, that APRI will be less sensitive as compared to FIB4, and NFS, FIB4 will be less sensitive as compared to NFS. But as the number of parameter increases, you need more tests and you need more software to calculate it. The easiest one is APRI, which can be calculated only with paper and pencil, and FIB4 can be calculated with online software. You just need ALT, AST, platelet, and age, which is done for every patient. And this is the most widely validated for fatty liver disease. APRI was primarily devised for viral hepatitis, and FIB4 was primarily devised for fatty liver disease. So if you are doing in community setting, what is the difference when you are doing a test in a community setting and when you are doing a test in a hospital setting? The difference is, in a community setting, your pre-test probability is less. Means if you screen 100 people, 2 or 3 will be at risk, will have risk factor. Pre-test probability is very low. But if they are coming to hospital, then 3 out of 10 will be at risk. So pre-test probability is high. So that can help you to decide which test to use. In community setting, we need a high predictive value test, which should be cheap, easy to available, right? And so the FIB4 is good enough. In clinical setting, means clinics or in hospital, we need where the high pretest probability you need high positive predictive value of test, more specific like elastography, fibroscan and MR elastography, anything whatever is available. So what message I want to give, that if fibroscan is not available, we should not think that we are handicapped and we cannot assess for liver fibrosis in our patient. This is a very beautiful graph. You can see two vertical lines, one is red and one is the brown. One is cut at 10%. This is empirically taken as 10%. If you are going to community, I don't expect more than 10% people will have significant fibrosis. Because 1/3 will have fatty liver disease, 20% will have NASH out of them, and 20% will have significant fibrosis. So roughly means 3 to 4% of fatty liver disease, means 2 to 3% prevalence will be there who will have significant fibrosis in any population. I am taking at 10%. Even at 10%, you see the violet line and the blue line, which is the blue one is the fibroscan and the purple one is the FIB4. Sensitivity for them is 97%. Means when you go to community, then fibroscan will perform as good as your FIB4. Or other way around, FIB4 will perform as good as fibroscan. But if you go to the another line, if you go into the hospital setting, then FIB4 is performing something around 88% as compared to 91%. Means even in hospital setting, FIB4 is performing just 3% inferior as compared to fibroscan. So it is not a thing. Only advantage that fibroscan is, it is quick, can be done in 2 minutes, no blood sample collection, not any instrument other than your fibroscan machine is needed, sample collection, transportation, serum separation, then reporting with pathologist and then calculation. All those things are out. That is the advantage. So whatever is available to you, you should choose your instrument, but rely both the instruments are very good to assess significant fibrosis. The best combination in a hospital setting to reduce the cost of care could be, first screen your patient with FIB4. Those who are having low FIB4 but at risk of fatty liver disease or significant fibrosis like with multiple comorbidities, then you go for fibroscan. That will save money for them and that will simplify the protocol. And the same has been adopted by, you can say, by our national guideline, which is showing that those with significant fibrosis should be further evaluated, and if FIB4 is less than 1, we need not to do much, or alternatively after less than 4.5, just manage at your center. So these two parameters have been accepted even in our national guideline. Now coming to what is new in the treatment in context of fatty liver disease. So these three things just I will talk, not every new thing. These are the three forms of vitamin E which is marketed, is tocopherol, tocotrienol, and a combination of both. What is the difference between the two? Just I want to highlight, other than the sources. When vitamin E is taken, it is absorbed going through the lacteals, splenic circulation. E is transported out with the help of a protein which is called ATTP, alpha tocopherol transfer protein. Tocotrienol, which is, and tocopherol. Tocopherol is alpha tocopherol, which has 100% binding with ATTP. Means the vitamin E, which has gone inside the liver, will also move out of the liver into the periphery, reach to every cell in the body, even when there is no vitamin E in your diet. But tocotrienol, which has very less affinity with ATTP, it will not come out of the liver, will not circulate to the rest of the body, but it will have more concentrated effect inside the liver, because it will stay in the liver and it will be excreted in the biliary tract. So that is the basic difference between the two forms of vitamin E which is marketed. This is the second drug which is not CDSCO approved, but off-label it is used, Resmetirom, and this is thyroid hormone beta receptor agonist basically. Thyroid hormone regulates the fat metabolism inside the liver, and prevents fatty liver disease. This was the phase 3 trial. Just in summary, not much of data, that Resmetirom has improved NASH in almost 25 to 30% of the participant as compared to 9.7% in control arm. And if you see the fibrosis improvement, it was again 25% in Resmetirom arm as compared to 14% in control arm. That means definitely Resmetirom seems to have a beneficial effect. As and when the drug will be approved and marketed, we can consider to use it. But what we need to know before we start using Resmetirom, we don't have long-term safety data of this drug. How long the effect will persist is a question. Most likely as soon as you withdraw the drug, effect will wash out because it is going to work as an agonist like any other drug. How long to treat, we don't know. What effect will happen in lean NASH patient who don't have that much of fatty liver, they most of the time have OTPT elevation. Effect in NASH without metabolic syndrome, we don't know because the participant were NASH with metabolic syndrome. Effect in those with more severe degree of steatosis. So all these are the questions which are still open for Resmetirom. Now coming to the last group of drug in last 2 minutes, as our previous speaker has discussed. Just what I want to summarize here, GLP-1, GIP-1 and the third retatrutide, all this drug works at 3 sites. Brain, they reduces the appetite. All these drugs create a sort of low-grade hypoglycemia in our body, but in response to hypoglycemia, we don't feel appetite because they suppress our appetite. That's why we start having side effects like nausea, fatigue, weakness, all these things happen. So you don't take food because you're not feeling appetite. That is why you lose muscle, because your intake has reduced. That is the problem. Second, it is working on pancreas to enhance the insulin secretion and the sensitivity. And third, it is working at GI tract to increase, basically delays the gastric emptying and increase the food staying in the stomach, so you don't feel empty. These are the 3 major mechanisms how this group of drug, or these 3 drug works. So semaglutide, yes, it has shown beneficial effect. I will not go much of this thing. Only thing I want to say, and these boxes I have placed at the label, the proportion of participants who achieve 10% or more weight loss with these drugs. Right? With semaglutide it is 70%, with orlistat it is 60%. Because 10% weight loss is the target for any intervention in patient with fatty liver disease. So, while waiting for other drug or the cost is an issue, we can consider to take help of these pre-existing drug to reduce weight along with the diet and the exercise. And this is the target weight loss, because when the weight loss is more than 10, then fibrosis regression is shown, particularly up to F2 fibrosis, but not higher grade of fibrosis. So, shall we choose diet and exercise or medicine for weight loss? I have summarized other things. You make your own decision, just I am giving you the perspective. How the diet and exercise is working, it increases the burning of the excess of fat, while medicine is reducing your diet intake. That is the difference. That is why, because your calorie intake is increased, so your protein intake is increased, so your muscle mass is increased. But in other case, your muscle mass is lost. And this is the summary of the meta-analysis of all the studies where this semaglutide and retatrutide is done, which has shown that 25% of your weight loss is happening because of muscle loss. 75% is happening because of fat loss. Right? So, that is the second thing. Third, exercise and diet has non-hepatic benefits. Heart, brain, kidney, bone and joint, everywhere. But this drug is not having beneficial effect on any other organ. And in fatty liver disease, mortality is determined by the cardiac event, not by the weight itself. So when we are using this drug for weight loss, it's fine. But when we are talking in context of fatty liver disease, then we have to consider these outcomes. That fatty liver disease patients are at risk of cardiovascular event, chronic kidney disease and other event which is determine their outcome, particularly cancer and these things. And this Exercise and diet will reduce those risks also, but drugs will not. So that is another benefit. Sustain weight loss. With diet and exercise, you can sustain weight loss, but with medication, this is not a sustained weight loss, and this is the 2 weeks ago it was published in British Medical Journal. Weight roughly 0.4 to 0.5 kg every month, and you go back to your pre-medication weight in 14 to 16 months. So that is very important. We are switching on our gas burner when we are cooking the food, but we don't let it switch on 24/7 at our home, even if we have money. And that is what is happening. These drugs are why God has made that GLP should be produced in our body only for 5 minutes, only for 10 minutes. And we are giving it for 24/7. So we are fighting with the physiology. Everything which goes with physiology is a better option than anything which goes against the physiology. We can have long-term side effect because, as I told that, because it will reduce the gastric mortality, so it has a risk of pancreatitis, it has a risk of cholecystitis, depression because it is working at brain, and several other important side effects, like one was vision loss. So cost is obviously a factor, but last, so I will summarize that NAFLD is accepted as a hepatic manifestation, but the diagnostic criteria remains the same as NAFLD. So आप उसे चाहे राम कहो चाहे रहीम कहो, बात एक ही है, उसमें कोई confusion नहीं है. And we should try to use non-invasive test to diagnose the fibrosis. We should not chase much on ALT, AST. We have to chase more on liver fibrosis, and FIB4 is a very good marker, at least as good performing as fibrosis scan when we are looking at the extent of fibrosis inside the liver. And weight loss is the key. I will prefer a physiological way of losing weight instead of a medicated way. Thank you.
Thanks, Dr. Amit Goel Saab, for delivering such a wonderful talk.
Number 2, there is no gainsaying the fact that physiology is best than pharmacology. There is absolutely no problem. Diet and exercise remain the cornerstone of managing obesity, hypertension, diabetes, and I don't know whether you are aware or not, there are 261 diseases which are associated with obesity. So there is no, except for Dr. Goel, who has reduced his weight by diet and exercise. How many of us are sitting here and have tried their level best to reduce their weight by diet and exercise, and whether this reduction in weight is physiological, a couple of kgs. So the problem with reducing weight with diet and exercise is manifold. One more comment that I would say is that with the use of these pharmacological drugs, we lose about 30% of muscle and 70% of fat. The problem is that when you stop the drug, the weight comes back, and it is only the fat that comes back. It is not the muscle that comes back. This is the biggest problem. And therefore, one should use these drugs, GLP-1 receptor agonists, with lot of patience, advice and counseling. And let me tell you, once you start telling them कि तुम्हारी मांसपेशियां ढीली पड़ जाएंगी, so many of our patients will certainly not resort to these. So I would like your first opinion on 5 liters.
Gain, etc. because of edema, but I have restricted myself only because my topic was liver things. That is the age-old thing. That's why I have not talked about everything. I restricted myself to. But yes, it is a drug which can be used.
Because we are all using 5 liters for this purpose.
Yes.
Regularly. But you are very right. Your topic was related to mainly on newer things. That's true.
One thing for our clinicians is that we have very rightly emphasized that using only FIB4 can at least diagnose those patients who are likely to go up or who can remain with the standard drugs and can definitely feel better.
Basically, the identifying high-risk patients is still a problem. How will you identify the high-risk patients? Because we are diagnosing them with F4 and F5 and F6. That is the biggest problem. If we do not treat these patients F2 as you told, then and at that stage it is very difficult. So what to do for these patients? That is how to handle these patients, how to catch these patients. That is the biggest problem. Because we are screening patients, you are doing F4, you are doing F3, you are doing NF. All these things, once the patient comes and he is already in phase F5 or F6, then the problem is you are not in a position to solve the problem. So how to do that? How to identify these high-risk patients? If there is there any answer?
Is with hyperlipidemia. Second thing, family history of liver cirrhosis, liver cancer. Particularly if the comorbidities are uncontrolled, like diabetes which is uncontrolled, so they will be at risk. Because in fatty liver disease we have to be very clear. Outcome is determined by two things. Those who are having cirrhosis, outcome is determined by their presence or absence of cirrhosis, not by any other things. Those don't have cirrhosis, outcome is determined by the cardiovascular disease, not by the liver person. Even if enzyme remains whole life elevated, it will not determine the outcome. Ultimately, the death happens with the cardiovascular disease. So, patient don't know I am having what thing. I am going to hepatologist because my OTPT was elevated. It's my responsibility to evaluate for diabetes, triglyceride, hypertension, coronary artery disease, and chronic kidney disease. So every person who is these are the patients who should be referred and further evaluated.
Thank you. On newer drugs like PPRA, alpha and gamma agonists, which are very much available and advocated for reduction of this MASLD. And the second thing, as a physician, the dietary advice to the patient to reverse this.
See, dual receptor blocker, they improves the OTPT, there is no doubt. There is no doubt. But biopsy-based data till date is available only for 10 or 12 patients, not more than that. And it is improving the fibrosis. And as I told, that outcome is determined by the fibrosis or by the cardiovascular outcome. So that is one truth we should know. Definitely it improves OTPT, there is no doubt about it. But when you stop the drug, it will come back. If the diet means, I strongly believe that all these drugs are useful. We should start this drug along with the diet and exercise. By the time his diet and exercise will take the effect, drug will give some placebo effect to the patient. He will start getting positive feedback that yes, it is working, and then you can stop him with medication and diet and exercise and continue to maintain his weight and liver health. That is how it should go. If you only bang upon diet and exercise, most of the people are non-compliant. But as you are, sir, myself have reduced 9 kg weight just by diet without exercise.
That's the only answer.
In 3 months.
Exercise is going to, otherwise diet is the only answer. Only answer.
I hardly send my patient to dietitian because if I send to them, उन्हें लिखते सुबह 2 इडली खाना, दोपहर में दूध पीना, शाम को 1 किलो खाना, होता नहीं है। क्या खाना लेके चलेगा आप इतने साथ? वो संभव नहीं लाइफ में।
One more thing. SUD, as you said,
कुछ नहीं उसने कर दिया।
liver fibrosis, but SUD is there now.
Yes, it happens.
That is the biggest problem. We are thinking that patient is normal, patient is no problem, but otherwise he is already in a bad state. Then
How do you calculate FIB4 then?
That is why I told that APRI was initially designed for viral hepatitis because APRI include only AST, but FIB4 include ALT also. Because it was devised for that thing, both position of both things are different. So fatty liver disease, most of the things are, both things are elevated that way. So it is validated, widely used, and also we have to see the feasibility, what is available.
What is the level of platelet that is important?
Most of the time it is considered more than 150, then it is normal. Less than 150 is considered as a risk for having significance.
So let's take more questions as
Just regarding pioglitazone, I have just comment. Pioglitazone is a very good drug for insulin resistance treatment and for fatty liver, but never for weight loss. rather pioglitazone causes weight gain because it causes adipocyte redistribution, so it improves fat from the liver, but it causes more deposition in the subcutaneous tissue. So it is never should be used as a weight loss drug.
Any more